Dr. Wilson. Thank you so much for taking the time for this interview. I broadly have two questions, and then we'll get right into it.
Okay.
The first is about what the situation is on the ground on your end in Wichita Falls, Texas. And the second one is about the article that you put out there.
Okay.
Was it yesterday?
Yes.
Yeah. And you outlined 10 action items that GI practices can take and endoscopy centers can take now. So I wanted to talk to you about these two questions. But first, how are you, and how are things where you are?
Of course, everything is different like everybody else. We're under the strain and stress of preparing for and dealing with the pandemic. We're in a small community, Wichita Falls, Texas, North Texas. We are a gastroenterology group, 7 doctors. We have an ambulatory surgery center. We participate very closely with our regional hospital. We're right across the street from them. Our ASC is right across the street from them. And we are the only GI group that covers hospital call for gastroenterology 24/7, 365 days a year. So we have a close relationship with our hospital. The epidemiology predictions for our community, we have been watching those very closely. And in fact, it's shocking how closely our rate of rise of this infection has matched those predictions. Today we have 38 people in Wichita County. Wichita County has 135,000 people. We have 38 people tested positive. About 1,000 people have been tested, but only 38 have been positive. About 300 are pending. 90% or more of the tests that have been done for patients of interest have been negative, which is great. We currently have 4 intensive care patients here that are patients under investigation. 1 is COVID-19 positive. Everything is different. The volume in our practice is greatly reduced. It's hampered by, shelter-in-place restrictions for our community. The community is sticking together for shelter-in-place, and everybody's encouraging that. I think it's going well here. Social distancing affects everything we do. Our volume at the ambulatory surgery center, our ASC is still open. We keep 1 room open 4 days a week right now is all, as compared to 3 rooms 5 days a week before. And we are only doing urgent outpatient endoscopy for urgent indications. We continue to have clinic, both face-to-face and telemedicine. Today, my clinic is about 50-50. I'll have about half of my patients will be telemedicine today, and about half will be face-to-face. New patients, most of the time, we're still seeing face-to-face. Some of them we're not, but physical exam is still, our policy has still been to see and examine our patients when they are new. Sometimes we offer telemedicine even for new patients, and sometimes those patients are choosing that option, which is fine. And then we have to follow up with them for physical exam at a later time. So that's what's going on here. I'm healthy. All of our staff has all been healthy. We've not had any patients or people under investigation in any of our organizations so far. Thank God.
Thank you. And what kind of steps have you been taking to protect yourself and your staff and your other colleagues?
Sure. Well, we've had a infection control policy in place for a number of years now, and our infection control policy applies to this infection as well. Now we have prohibited people from the building. Visitors are not allowed into any of our buildings, only the patients. They are tested for fever, and they are pre-screened by telephone the day before and upon arrival at any of our facilities. In fact, we like to pre-screen patients 2 or 3 days before for the appropriate questions of risk factors. Anybody with respiratory symptoms, fever, or exposure to people in their household for those symptoms is going to be excluded from the building until they've been tested for COVID-19 or until they've been quarantined for 14 days. So that's currently our situation in the clinic. I'm encouraging and walking through the building all the time. Our waiting rooms are empty, both at the ASC and at the clinic. Social distancing is encouraged and maintained in all the staff areas as well. Most of our meetings are now, teleconferencing meetings or strictly following the limitation of the size and the social distancing. So we're doing all those things. PPE. So patients who are considered low risk, who have screened negative, we're using standard PPE, face shields, surgical masks, waterproof gowns, gloves, hand washing, etc. And we are not doing patients high risk. If they have respiratory symptoms or exposures, then they are not being done. If those patients need to be done in the hospital, they're being done with N95 masks and full PPE. So.
Mm-hmm. I'm curious, these patients who are getting all these surgeries rescheduled, or, the GI symptoms don't go away.
No.
But now, COVID-19 takes precedence. So what happens after, hopefully we flatten the curve and we
Sure.
move past this phase? These patients with GI symptoms, wouldn't they be worse off?
Well, I tell you this,
Yeah.
this is not a 2-week or 3-week social distancing, shelter-in-place kind of thing for us. We have to be planned for the long term. This is a marathon. It's not a sprint. That means those patients with urgent elective indications, trouble swallowing, persistent diarrhea, persistent abdominal pain, colitis, etc., bleeding, GI bleeding, those patients are not going to be able to wait 2, 3, 4 months. So we're trying everything possible to put those patients off. Now, we're watching our epidemiology curve. If things continue as they are, we will have a patient surge here that fills our ICUs and our hospital about the 3rd week of April. And that's what we're preparing for. However, we're not anticipating being able to lift the prohibition on elective procedures until perhaps mid-June. So right now, June at our ambulatory surgery center is already filling up because we're still seeing patients. And right now we have hundreds, maybe 400 patients already scheduled for June, patients that normally would be scheduled probably next month. July is also starting to fill up. So it's important, in my opinion, it's critical that we plan for the continuity of our practices, right? We have to protect our staff, support our staff, and the infrastructure of our practices and our ASCs. I think that's a public health concern because those indications are not going to go away. So patients with more urgent indications, we're going ahead and doing those procedures in our ASC now. I don't think this is the right time to push those patients off to the hospital. And we're working very closely and with full support of our hospital. We have at our ASC a full supply of N95 masks. The hospital has offered those to our ASC if necessary. We're working closely with the hospital, the emergency room, the clinical decision unit, the transfer center, and the GI team on call to try to avoid using the hospital for low-risk patients, COVID-screened negative patients. We don't need to do those in the hospital setting unless it's a true emergency.
Okay. Thank you. So let's get to the article that you published and all these resources that you've been sharing. You talked about 10 specific action items that GI practices and endoscopy centers can take right now. Could you share a few of those? And then when I share this video, I'd like to share the article and the presentation.
Well, these are, of course, my opinion and things that are working for us here locally. First of all, I petitioned our hospital for an emergency expansion of our PSA, our professional service agreement, immediately. And they were very cooperative. So we have expanded our normal PSA, on-call, financial support, pay per call, etc. We've dramatically expanded that support from the hospital. Why is that? Because they share our goals. They're very stressed. They need specialists to help and support hospitalists, intensivists, people in the hospital. As the volume of patients rises, so will the number of gastroenterology issues that will rise. As you said, those problems are not going away. Liver disease, GI bleeding, abdominal pain, whatever. Those patients will need to be served, and done so with rapid, short hospital stays, rapid discharge, rapid endoscopy, or care coordination as an outpatient. We can help with that. So what they've agreed to do is give us full support for a second gastroenterologist on call. We call that person G2. We are then, so the expansion of that PSA with your hospital, I urge practices to approach their hospitals immediately for that. I think they should be cooperative. You share their goals. Here we are maintaining, number two, we're maintaining outpatient endoscopy capacity. Even if it is much less than before, we're going to try to not push those procedures off to the hospital. The anesthesia service is going to be a very important part of expanding the ICU capacity at our hospital, and they're not going to want to be doing anesthesia in the hospital for endoscopy unless necessary. Number three, we're supporting our staff. We are paying our staff and keeping them on as much as possible. It's a high priority. So I call that a business continuity plan. We plan to utilize whatever federally passed care legislation benefits to help us do that. Most importantly, the payroll protection program, we are perfect for that. So, we're a business under 500 employees. We will retain our staff. You must retain your payroll. And so what happens there is that the Small Business Association, through local lenders, will forward us a loan amount of 2.5 times our monthly payroll, average monthly payroll over the last 12 months, as long as we retain at least 75% of our payroll during that time. If we don't, we have to pay the money back. If we do, it's largely forgiven. That's an outstanding benefit that we plan on taking advantage of. We are also, at the Ambulatory Surgery Center, allowing our staff to borrow PTO, up to 80 hours of PTO from the future. Things that might be automatically deducted from their paychecks, a lot of those things are being forgiven right now. For instance, previous medical bills or previous loans against their retirement accounts. Those things they're not having to pay right now. So supporting the staff is critical. Continuity plan, long-term again, for your business. The next things are things that relate to closely working with the hospital. Patients are losing their insurance. People that lose insurance have lack of financial resources. They're a little bit harder to get out of the hospital. So we are actually participating in our transitional care clinic here. A transitional care clinic is a clinic that the hospital has for patients immediately after discharge, regardless of their ability to pay. So when a patient, is on the edge of whether or not they should stay in the hospital or not, or care is not fully coordinated, they don't need to stay in the hospital because they can come to the transitional care clinic. We are participating there for patients with digestive problems. So those patients will be seen by the G2 second gastroenterologist on call and help care coordination and make sure those patients are getting the best possible care, shorten hospital stays, etc. The ER, the clinical decision units in the hospital, we're working with those closely, and the transfer center. So now the transfer center knows we're eager to talk to outlying facilities, other hospitals that normally refer in, outside providers. We're eager to talk to them first if they have digestive questions so that we can coordinate their care as an outpatient rather than in the hospital. Avoid some of those transfers and have them taken care of. Some of those patients could actually now be sent to our ASC. If they're COVID negative, properly pre-screened, low risk, they can be seen at our ASC. And CMS has expanded the ability for ASCs to work in that kind of capacity. Of course, telemedicine, teleconferencing, we're doing a lot of that. We are, like I said, about 50% of our visits now are telemedicine. That's working extremely well. That will continue to evolve, I think. Maybe using technologies in the hospital, by the way. Teleconferencing technology that allows us to see patients in the ICU or in their patient rooms without physically going in there. So we can round on patients remotely, reducing exposures, etc. They are wiring up that kind of technology at our hospital. And then maybe teleconferencing consultations with outlying facilities. So those are some of the things we're also doing. You know, right now a lot of meetings happen. I've encouraged my colleagues to make meetings regular, structured, and highly efficient. We don't have time right now for lots of unstructured conversations. So we are having twice weekly structured meetings, all the stakeholders, the endoscopy center, the hospital, the practice, the administrators, to go over things quickly, status in the hospital, how many GI census patients are there, how many of them are being affected by COVID, how many are patients under investigation, what's happening in the transfer center, the transition clinic, etc. We're going to be having those structured meetings regularly. Really ramping up and making sure the infection control plan is in place, and then taking care of ourselves. Those things are all things I recommend.
Well, Dr. Wilson, thank you very much for your time and all these action items that you've shared. Please keep the resources coming, and I wish you well and your staff well, and do stay safe. Thank you.
Thank you, Praveen. I wish you good health during these times. Thank you.
Thank you.